So today our speaker is Dr. David Nix, who's a professor of pharmacy practice and science at the University of Arizona Arkham College of Pharmacy. He received his Bachelor of Science in Pharmacy in 1982 and PharmD in 1984 from the University of Georgia. From 1984 to 1986, he completed a postdoctoral fellowship in infectious diseases, pharmacotherapy, and pharmacokinetics from the State University of New York at Buffalo. From 1986 to 1996, he served as program director, antimicrobial research, assistant director, and associate director of the Clinical Pharmacokinetics Laboratory at Millard Fillmore Hospital. Dr. Nix was responsible for directing the clinical pharmacology unit and carrying out clinical and laboratory research involving antimicrobial drugs. Dr. Nix then joined the University of Arizona faculty in 1996. He practiced as an infectious diseases pharmacist, both in general and transplant, from 1997 to 2024 at the University Medical Center, which later became the Banner University Medical Center for the last decade. His research has involved treatment of valley fever, development of Nicomycin Z, pharmacokinetics, safety, drug interactions, and optimal dosing of antimicrobial drugs, especially fluoroquinolones. Dr. Nix has authored or contributed to over 110 research papers, and he's board certified in pharmacotherapy specialist, infectious diseases pharmacist, and board certified in applied pharmacology from the American Board of Clinical Pharmacology. So thank you, Dr. Nix, for joining us today. And without further ado, I will hand things over to you.
Right, thank you. So I just started reflecting on some of my experiences from before to kind of give you an idea of where I'm coming from. Let me find out. Let me get this to advance. Here we go. So I'm going to start off and talk about aminoglycosides. And it's because when I first started practicing back in the 1980s, 90s, um, aminoglycosides were pretty much our backbone for gram-negative infections. Uh, so that's one area that I got a lot of experience in. And when we added beta-lactams, it was basically for a perceived synergy or some kind of benefit of additive therapy. Um, the first two of those drugs that I'll just talk about are carbenicillin and ticarcillin. And these were generally thought of as protective for aminoglycoside toxicity. And the mechanism of this was always a little bit in dispute, but some of the possibilities was that it was from sodium loading. So both ticarcillin and carbenicillin are sodium salts, and there's quite a bit of sodium in the dosage forms. In fact, I've seen a couple of people go into acute heart failure from getting carbenicillin and ticarcillin from the sodium load. But at any rate, there's also a potential for a chemical interaction between the penicillin derivative and aminoglycoside that would inactivate the aminoglycoside and make it less toxic. So back in 1995 or so, I did this experiment where we actually brought healthy volunteers in and gave them gentamicin. I know everyone would kind of turn purple if they saw that today, but it's one of those things. Back then, we used a lot of aminoglycosides, and pretty much anyone who came into the hospital with gram-negative infections it was kind of the empiric go-to. So I looked at 8 people getting each of these therapies: gentamicin placebo, gentamicin ticarcillin clavulanate, and then in a second protocol, we looked at piperacillin and ceftazidime in combination with gentamicin. And these are renal enzymes. So basically, it's the same idea as looking at liver enzymes. When you get injury to the liver, you get spillage of ALT and AST in the serum, and you can see those go up. And the extent of how high they go up is pretty much related to the extent of the injury. So these two enzymes are N-acetyl beta-D-glucosaminidase at the top. And what we did there basically is you look at the subjects getting placebo and gentamicin and then the 3 drugs on the right. But you will find that the combination of gentamicin and ticarcillin clavulanate on the left there has lower enzyme excretion than the gentamicin alone. And that's that protective effect I was talking about. So on the right, you see that piperacillin does not really have that protective effect. And at the time, we were thinking that that was due to the fact that there's a lower sodium load in piperacillin. And it was, especially with this particular dosing, we used 5 grams every 8 hours, which took advantage of this saturable tubular secretion that you get with piperacillin. Uh, but you'll notice that ceftazidime is much higher. And that's because in those days we think of uh, cephalosporins as being potentially nephrotoxic. Penicillin generally is protective as a whole. Uh, and at the bottom, you see the same type of relationship. It's just a different enzyme. It's alanine aminopeptidase. So that's how I went into this thinking is that, well, penicillin should be protective. Why is piperacillin causing this acute renal injury? So the other thing I'll talk about briefly is that vancomycin nephrotoxicity has been perceived differently over the time that I've been in practice. So there was a time even before me in which vancomycin was given and we didn't do therapeutic drug monitoring. And there were cases where vancomycin 2 grams was given daily, and a person had renal failure and were on dialysis. And you can imagine with what you know today of how what the levels of vancomycin would climb up to after about 5, 7 days of therapy. Um, so at any rate, that's when reports of ototoxicity and nephrotoxicity first started coming out. And we now think of vancomycin as not ototoxic. And there was a time around 1980s when we thought that the nephrotoxicity was overblown. Uh, so at that time, we were trying to get trough concentrations in the 5 to 10 range and peak concentrations of, if I remember right, 35 to 45. So quite less exposure than you're getting today with the trough levels and AUCs of 400 to 600 and troughs of say 10 to 20 and 15 to 20 in some places. So at that point, we were talking about aminoglycosides as causing nephrotoxicity, but only in select populations and only when given with other nephrotoxic drugs, they tended to enhance the toxicity. And then, of course, we started thinking about Visa and Versa. So vancomycin intermediate Staph aureus and vancomycin resistant Staph aureus. And they never have really taken off. We could argue about Visa a little bit, but Versa has been, I think, 16 cases to date worldwide that have been reported through the United States. So it's just not going to be a huge thing unless something major happens. So we push the trough concentrations up to as high as 15 to 20. And under certain circumstances, that could get you AUCs in the 800 range. And we started to see nephrotoxicity. No one would deny that. And that's sort of that second hump there. And then in 2000, we sort of backed up a little bit on the dosing and said, well, we need to make sure the area in the curve is not greater than 400 to 600. So this just sort of illustrates that our situation before in the 1980s is that we had a fairly broad therapeutic window with vancomycin, and we had some leeway there. The toxic effect didn't occur until higher doses were given, or somebody was on combination therapy that in itself was synergistic nephrotoxicity. But what we ended up producing, and particularly before 2000, was this narrow therapeutic index where we were pretty much at the maximum dose that we were going to get away with. And we did see more nephrotoxicity. So let's talk about just for a moment of how important piperacillin-tazobactam is. So we don't really do not have that many workhorse drugs. These are drugs that we would put people on for empiric therapy when we're trying to cover a broad range of gram negatives, uh, particularly if you wanted Pseudomonas coverage. So you've got piperacillin-tazobactam, cefepime, and carbapenems. And of course, we're trying to minimize the use of carbapenems to try to deal with all of our carbapenemase resistance and all that. So that leaves piperacillin-tazobactam, and cefepime. They all three have Pseudomonas coverage. Piperacillin-tazobactam is probably a little bit lower, 5-10% lower. And they have broad spectrum coverage. Two of these, pip/tazo and carbapenems, will cover anaerobes. Well, if you don't need to cover anaerobes, covering anaerobes is not a good idea. There's a few studies that have shown that you have increased mortality when you overtreat the anaerobes, and that causes dysbiosis of the GI tract more so than not including anaerobic coverage. And then finally, ESBLs have become much more plentiful. ESBL production by gram-negative organisms like E. coli and Klebsiella and any of the other Enterobacterales. And pip/tazo is probably okay for empiric coverage until you get identification of that organism. And it's okay even if you identify an ESBL and you have a UTI. So those have become some more common uses. And of course, carbapenems are a drug of choice there, particularly if you have a systemic infection. So these are really important workhorse drugs. And you'll find hospitals that use preferentially pip/tazo. You have other hospitals that preferentially use cefepime as their workhorse drug. So drug-induced kidney injury. So for those of you that if you're a clinical pharmacist, you can kind of take a second break. But I just want to mention how these substances is used. So creatinine is produced in muscle tissue, fairly constant rate. And if everything stays in good equilibrium, you should have a constant serum creatinine level throughout the day with some little bumps associated with eating a meal or something like that. But it stays fairly constant. If your kidney is responsible for getting rid of it, if you have kidney failure, that level is expected to go up. And we would call that acute kidney injury because your kidney function is actually decreased. So we monitor that in the serum. We generally have a definition of acute kidney injury as being a 0.5 milligram per deciliter increase in your serum creatinine. There are some other methods that use 0.3, but I would say the majority of them are 0.5 milligrams per deciliter or a 50% increase in the value. So there's also something called pseudonephrotoxicity. And so most of us have about 90% of serum creatinine coming out through the kidneys is filtered through the glomerulus. About 10% of the serum creatinine goes through a different pathway where it goes through across transporters through the cells and into the urine. We call that secretion. So if your secretion is 10% and we have something that blocks that secretion, your serum creatinine will go up just a tad. If you have some disease underlying that makes you secrete more serum creatinine, then it might go up quite substantially. In some cases, about twofold. So the first reports of this kidney injury came out around, we'll say 2010. So they were meeting abstracts. And I think I found about 3 or 4 of these meeting abstracts where they presented a combination of vancomycin with a beta-lactam. And it was always one of those beta-lactams was vancomycin plus piperacillin-tazobactam. And this first study that I found was a retrospective study at St. Louis VA Medical Center. And they looked at patients over a 5-year period. And specifically these combinations, vancomycin, piperacillin, tazobactam versus vancomycin, cefepime. And what you find that the percentage of patients actually experiencing that acute renal failure or acute kidney injury, we'll call it, uh, was about double for piperacillin-tazobactam vancomycin combination compared to the cefepime control. And particularly, this is all patients, 13.3% versus 29.3. This is patients based on their vancomycin exposure and dosing and all that. But you generally see that piperacillin combinations had more acute kidney injuries. This was another study that was published in 2014. The incidence here was 12.5% for the comparator, cefepime and vancomycin, and 35% for piperacillin, tazobactam, and vancomycin. And you can see that we classify them according to stages. A lot of patients had mild disease. You had some with moderate, and that one actually reversed in terms of the magnitudes. And then some of them had grade 3, which was more renal failure or very rapid reduction in kidney function. Um, let's see, I think those were, let me just go on. So this is another study, and a lot of these studies looked at piperacillin tazobactam combination versus cefepime combination with vancomycin. What changed over time is there were more and more of these studies that got larger and started to look at how can we make these groups comparable. So these were all retrospective studies and they captured people, but there might be bias on how one drug's used versus the other, and that would affect the end results that you get. So we had a number of studies that were done with matching, and I'm only going to show you the larger studies. There were dozens of these studies published within a 10-year period. So this looked at 10,000 patients. And you see that they were excluded from different reasons. And so you end up with about 4,200 that received cefepime, FEP is cefepime, and vancomycin versus tazobactam, piperacillin, and vancomycin. And you can see that this particular center had a bias towards using piperacillin tazobactam. The numbers are much higher for that compared to cefepime. Then they basically look at a matched population, 3-to-1 match, based on these criteria over to the right. That's baseline creatinine clearance. That's IV contrast material that is also nephrotoxic, so it would be concomitant nephrotoxin. This was at the University of Kentucky. And over, let's see, how many years did they look? I think that I don't remember exactly, but it was about 2-year period, I believe. And you use, vancomycin is the number one antibiotic at most hospitals. So in terms of usage level. So if you look at any acute kidney injury, you see 12% with cefepime, 21.4% with piperacillin tazobactam. So more than double, a rate ratio of, I think this comes out around 2.3. This next study was at Detroit Medical Center and over a 2-year period. And they turned it around a little bit and looked at time to event analysis. And you can see what happens over time here. So this was acute kidney injury related to vancomycin cefepime down at the bottom. Maximum is about 11% at day 9, but you can see it kind of goes up over time. And this is basically piperacillin-tazobactam with vancomycin, and it goes up to almost 30%. So this is getting close to a 3-fold increase in serum creatinine as a result of that combination. So this is the actual monotherapy. So one of the issues that you would want to look at, so I'm glad this study was done, is does piperacillin-tazobactam have any toxicity that was missed originally? So what you find is vancomycin monotherapy, somewhere around 7%. The piperacillin-tazobactam monotherapy, somewhere around 8.5% or so. And then the combination of the two up around 28% or so. So basically, combination therapy has, now what's this acute kidney injury here? That's just background. So if you're in a hospital and you're septic and you have infections, you have other insults to the kidney, there's going to be some background. And I think that's what you're seeing with the monotherapies, but the combination looks somehow synergistic almost. So we'll come back to the local situation. So this is Banner University Medical Center, and 2018. So that was right, that was still Banner, I think. So Banner had 3 large hospitals in Phoenix, and I don't remember off the top of my head exactly which one of those were included. One of them is obviously Banner Medical Center, Phoenix, to the university campus, UMC Phoenix, and 2 other, I think one was Desert, but there was another one that was looked at in the ICU population. It was a retrospective study and covered 3 years. There was 2-to-1 entry for vancomycin pip/tazo versus cefepime combination. And there were, oop, got a flicker. Let me get back to the right place here. Okay. So you had all these exclusion criteria, which made total sense. Excluded pediatrics, so only adults, people with a pre-existing renal failure, and people that had antibiotic therapy for less than 48 hours. That was the majority of them. And you end up with 817 that meet this criteria with pip/tazo and 133 that had cefepime plus vancomycin. And they ended up, when including the matching, they only included 200 of these. AKI incidence 17.3 for cefepime and 19.5 for pip/tazo. So this was not a significant difference. And this was different than the majority of the data out there. So why? I wish I could answer that question. It's kind of like answering the question about why we're seeing NDM in Arizona when other states are seeing KPC types of resistance. So at any rate, you can see that no difference was really that important. There's a little bit of difference here for number of cases with less than 3-day onset of AKI. And then there was another study done at Honor Health in Phoenix, and same drugs, and they confirmed no difference in AKI outcomes in ICU population, similar to the findings at Banner. And this was Dr. Buckley and his colleagues did a repeat study a few years later. This was a 2-year study, and they looked at vancomycin in combination with piptazo, cefepime, and meropenem. And so we added a carbapenem this time as a drug that is thought of as not having acute kidney injury. So they looked at a much larger number of hospitals. I know the Banner system has 26 hospitals, but they pulled in a bunch of the medium size, included the data in this data set. AKI incidence was 21.9% for piptazo and 16.8% for the other two drugs in combination with vancomycin. That to me is not a large difference in the incidence of AKI. It was significant. That's primarily because this was a large sample size. So it was easy to demonstrate significance. But from a clinical perspective, that's not a big gain. So to me, it confirmed the results of the first study. And the result was driven by mild AKI, which resolved in less than 3 days. This was a study done at the Barnes Jewish Hospital in an ICU population, just to kind of add some ICU flavor to some of the previous studies. And they did multivariate analysis to control for confounding factors. We never know if we have all of those confounding factors, though. So this was another time-dependent study. This is a Kaplan-Meier curve. If you look at the case of Piperacillin-tazobactam, almost 50% of the people had acute kidney injury by 15 days. So roughly 50%. And the other two cases with cefepime and meropenem, the percentage of people that survived without kidney injury were around 75, 76%. So this was, and then now it's starting to get a little bit interesting. We're starting to ask some questions about this and what it means. So this is a uh, ongoing prospective cohort study looking at sepsis, and it's called the Molecular Epidemiology of Sepsis in the ICU Project. So it's prospective, observational, but not randomized. So there still can be some bias in what patients receive for therapy. So this is vancomycin plus a beta-lactam. The beta-lactam, or you had to have a baseline cystatin C. Now, cystatin C is an alternative biomarker of kidney function. It'll go up the same way that creatinine goes up. And if cystatin C has other things you have to worry about for that might affect cystatin C, but I found it to be extremely useful in my setting. And the other thing is the patients had to have a follow-up cystatin C within 48 to 72 hours after the combination was initiated, the antibiotic combination. So it's just another way of looking at the same problem. And what we found here, if you look at the number of patients that had more than 50% increase in cystatin C, so this is 1.5x, you do not see a difference between the case of vancomycin and cefepime versus vancomycin with piptazo. There was also some analysis. This is called inverse propensity treatment weighting. And it's a way of adjusting for differences between the two populations using propensity weighting. And that's basically looking at the likelihood or probability that you're going to assign patients to receive pip/tazo versus cefepime based on a number of criteria. With the adjustment, that comes out to be about 1. And even without the adjustment, this is not a significant deviation from 1. So cystatin C shows that there's no changing. If you look at creatinine, it has a rate ratio of somewhere around 2. With the adjustment, it's 1.86, not significant. Or actually, yeah, not significant, but it is significant with a crude marker. So what this is suggesting is that creatinine is picking up something that cystatin C is not. And they also looked at BUN, which is another marker of kidney function. It just has a couple of other confounding variables to worry about. And again, no real difference. The difference is not significant. It crosses over 1. So in this particular study, 192 participated in the cystatin C sub-study. They had samples archived that they can pull out and measure cystatin C in many of the patients. And if they looked at the, I went backwards somehow. At any rate, what this study suggested is that we have this pseudonephrotoxicity, and cystatin C is not secreted, creatinine is, and we may be blocking that secretion. And we would consider this not a real loss of kidney function, but just a loss of creatinine excretion. And of course, cystatin C suggested there was not a difference. So then my colleague here, Sid Pattenwala, who's in Australia now, had access to this database. And it's a very large database, including about 260 hospitals in the United States. So we started thinking about this problem and how we could look at it, and decided that we're going to look in the ICU population in patients with septic shock. And septic shock was identified by ICD-10 coding, which I think they've gotten pretty good at now with all the studies and interest in sepsis. Okay, so patients had septic shock. It was from this large premier healthcare database. And one of the benefits of having such a large database is that you sort of mix up hospitals, because they are hospitals that really focus on using pip/tazo, and there are hospitals that use a lot more cefepime as their first line therapy. And you kind of mix those up and you get rid of some of the bias that you get if you have a single center involved. So we found 19,000 people with septic shock. The analytical cohort, when you get rid of people with pre-existing kidney disease that receive both cefepime and piperacillin-tazobactam and receive drug for less than 48 hours and all that, you end up with 8,427 that got cefepime or pip/tazo, and you can see that those numbers are kind of in the comparable range. We used this inverse propensity weighting for adjustment, and you can kind of see without adjustments what the numbers look like. And then if you sort of, I mean, it does a lot of the adjustment internally, but it sort of messes with the weighting of the numbers and all that to make the groups as comparable as possible. These are infection sites. Most of the patients had either lung infection or urinary tract infection, which is obviously the most common. And the intra-abdominal is kind of interesting and perhaps skin and skin structure because this will get at the need for anaerobic therapy. And that, as I mentioned before, using anaerobic therapy when it's not needed is not a good thing. So these are patients with stage 3 AKI. And we looked at stage 3 because we thought it would be clinically important. And you see that there's no difference in stage 3 acute kidney injury in these population. Either got cefepime or piptazo. They're basically superimposable. The stage 1 and the stage 2 are pretty comparable as well. This is basically acute kidney adverse kidney events. Sorry, this is adverse kidney events. Another definition. These are patients who died, and RRT, none of renal replacement therapy. So none of those are significant. And hospital length of stay sort of trended a little bit, but again, not significant. This just shows that that's superimposable as far as the two drug therapies. And I didn't really expect it to come out this comparable, but it really is superimposable. And I think it has something to do with getting the right population together. But then we have to still ask that question about pseudonephrotoxicity that one study with cystatin C suggested exist. This is just more work. These are the variables that we did the propensity weighting versus, and just showing that they are not different by group and all that. And they all cross over across one, which says it's not significant. So then we go back to preclinical evidence for this toxicity and try to figure out what's going on. We know that there are increased urinary markers for this vancomycin piperacillin-tazobactam combination versus monotherapy. And there's two new markers that are used more for screening drugs for kidney toxicity. And this would be metalloproteinase 2 and insulin-like growth factor binding protein 7. And we know that from these studies in mice and rats, the vancomycin piptazo combination is not associated with worse histologic changes than vancomycin alone in a rat model. And so there's a couple of studies that looked at that. In a mouse model, vancomycin causes doubling of serum creatinine and BUN, and there's histologic changes and increased renal biomarkers with doses of 3,500 milligrams per kilogram. That's a huge dose. So the other interesting thing is that if you did once daily imipenem plus cilastatin plus relebactam and piptazo, they're actually protective for nephrotoxicity. If you did it more often, like Q6 hours, same dose, it's lost its protectiveness for some reason. And I can't say I understand that. And then finally, we had this large ACORN trial, which was a randomized clinical trial of cefepime versus piptazo in adults hospitalized with acute infection, 2,500 in. And there was no difference in infection outcomes. Cefepime was associated with more common neurologic dysfunction. There was no difference in acute kidney injury, though. And 75% of those patients received concomitant vancomycin for their therapy. So ACORN trial, when you look at the details, a lot of patients got less than 48 hours of therapy before they would switch off to something else. And most likely definitive therapy once they got cultures and susceptibility back. Um, so I think most of the studies that I'm showing you had 48 hours as a minimum duration of therapy. And so it's going to be people that were exposed to the drugs longer. So I'm not sure the ACORN trial helps us out that much in that respect. A couple of things for the future. And some of you are look at microbiology data and breakpoints and resistance tabulation. So CLSI a couple of years ago looked at new breakpoints for piperacillin-tazobactam, and they proposed a susceptible range of less than or equal to 4 and a new range of susceptible dose dependent between 8 and 16. And before that, everything was susceptible between or 16 and less. Uh, so the other thing that comes with that is they did dose simulations in pharmacodynamics to show that if you had a higher MIC, you should be using a higher dose of peptazo, and that would be 4.5 grams every 8 hours with a prolonged infusion. Or if you're going to do no prolonged infusion, it would be every 6 hours. Um, so the one thing I learned early on is a lot of these were dose dependent. So if you do piperacillin by itself, and a 3 gram dose versus a 6 gram, you get a lot longer half-life with the 6 gram dose or 5 grams because you saturate the tubular secretion and all that. So I think one of the things is as we increase the dose, we might even see more of this interaction with piperacillin-tazobactam and vancomycin. And the second is pseudonephrotoxicity. Uh, we think that creatinine is excreted by OCT2, which is organic cation transporter 2 in the kidney. Uh, that can be saturated. And if you increase the dose of piptazo, it's not unlikely that that would become more prominent. So I think that is an issue that we need to look out for. I'm just going to summarize and say that many, but not all, retrospective studies show association between vancomycin and piptazo and acute kidney injury. Whether this association represents true nephrotoxicity is controversial. However, the lack of histologic changes in animal models and alternative explanation of pseudonephrotoxicity should prompt restraint. And I think probably we could fix this in the next few years. And one is to use cystatin C more often. In my institution, the last time I was ordering this, it took 4 days to get it back. Uh, and there are hospitals now that are including it as routinely available, and you can get it within the same day or so. And I think having this as a secondary check will make it easier for us to figure out which one of these are important and which ones are not. I can say at the present, I rarely do anything to change therapy with a minor bump in serum creatinine for this. Now, some of the physicians are going to get a little bit more uh, concerned about it, and they're going to change therapy to something else earlier. But I haven't seen many of these that progress to any significant renal failure. It's pretty uncommon. So with that, I'd like to open it up. If you guys have any questions, I'll try to address best I can.
Thank you, Dr. Nix, for that fantastic presentation. Really appreciate it.